Good morning. In this video, we are going to continue our discussion of the very interesting clinical case which we started in the past video titled Chronic Diarrhea, and in which we had an old lady, 63-year-old lady, who was suffering from chronic diarrhea that lasted for a month. And this female was on steroids for 30 years, on anti-inflammatory drugs like diclofenac, analgesics like Panadol. And there were many possibilities that we discussed together. We discussed about 9 possibilities. And in this video, we are going to discuss one more but very important possibility, that is inflammatory bowel disease, or IBD. What does the term IBD refer to? It refers to a group of chronic disorders. Then it could match with our patient's condition because it refers to chronic disorders. And we all know that what chronic means is that it has a slow, gradual onset, a progressive slow course, and the symptoms are not very severe. And they are characterized, this group of inflammatory bowel disease does not include only one disorder, but several ones. And the main characteristic is persistent chronic inflammation. There are 2 primary types for IBD, which are Crohn's disease and celiac disease. We already discussed celiac disease in the previous video, but we're going to focus more in this video on the pathogenesis of celiac disease and how and why it develops. But we are going to add a third item in addition to Crohn's disease that you see on the screen and celiac disease. I've added a third item to the document, which is ulcerative colitis, which is also a very interesting case that matches with chronic IBD, or inflammatory bowel disease. But that doesn't match perfectly with our patient's condition because it's usually associated with bloody stools, which is not the case in our patient. But based on the information that we provided in the previous video and at the beginning of this video, as I've just said, ulcerative colitis does not match exactly. Crohn's disease does not match exactly neither, as we will see very soon. So most probably it is celiac disease due to gluten sensitivity, as we have discussed in the previous video shortly, and that we will be discussing in details in this video. Is it possible that it is Crohn's disease? Yes, because Crohn's disease appears at the age of in old ages, and therefore, since she is 63 years old, then it is possible that it would be Crohn's disease. But it's not very likely because the disease usually affects a younger age group. It's unlikely, very unlikely, for Crohn's disease to start that late when a person is more than 60 years old. But there are certain features that support Crohn's disease. So we say that Crohn's disease is likely, but it's not very likely. The possibility is not very high. So in this video, we are going to discuss why it would be possible that this chronic diarrhea is caused by Crohn's disease and why it's unlikely. So chronic diarrhea is supportive, abdominal pain, weight loss, anemia, of course, because of the loss of food nutrients in the stools, low albumin for the same reason, because chronic diarrhea means that you lose nutrients that should be absorbed or that should have been absorbed. You lose them in stools. And we should have elevated inflammatory markers like CRP, serum C-reactive protein, and erythrocyte sedimentation rate, or ESR. And you know that both CRP and ESR are elevated in cases of inflammation. If it is Crohn's disease, it's not only about an elevated CPR and ESR, but also there is a specific test that is called calprotectin. So fecal calprotectin. What is fecal calprotectin? It is a non-invasive test, of course. It's a stool test. And it measures the level of a certain protein called calprotectin in the stools. What is calprotectin? It is a protein that is released by the white blood cells when there is intestinal inflammation and when the white blood cells are recruited to the intestines. You know that white blood cells might die after their battle against any foreign, what they consider foreign body, and they release certain chemicals. Among these chemicals is a protein which is calprotectin. So the presence of calprotectin indicates an immune reaction and therefore matches with Crohn's disease, which is considered an autoimmune condition affecting the small intestine. Of course, if the patient has colonoscopy done or any kind of imaging, we will find ulcers in the mucosa of the intestines, but the ulcers are not as equally pronounced as in case of ulcerative colitis. But there are certain features in our specific condition that we are studying of that 63-year-old female who has been suffering from diarrhea for a month. The first fact that there wasn't blood in stools, although blood in stools is not a common finding in Crohn's disease. The second is that the pain was essentially epigastric, upper abdominal, which means that it is less likely to be a disorder in the intestines, and it was relieved by defecation. Our patient had normal routine stool studies, but this is equivocal, meaning that it's not with or against Crohn's disease. As I've just said, the epigastric fullness, the epigastric tenderness, the bloating and the early fullness that occurred just after taking a meal are more matching with a gastrointestinal disorder or a motility disorder, mainly gastric actually, not gastrointestinal, and a motility disorder, as we discussed in the previous video. It might be due to slow peristalsis in the esophagus, which we call esophageal dysmotility, or it might be due to slow peristalsis in the stomach, which we call gastric paresis. So if you as a medical doctor are suspecting Crohn's disease, so there are 3 investigations that would settle your diagnosis. The first one is the stool screening test called fecal calprotectin, which we have just discussed, and which is a protein released by the white blood cells in case of immune responses to inflammation. The second is a procedure called colonoscopy. So you introduce your colon from the rectum, and or maybe an upper colonoscopy for the stomach and the small intestines, and you carry out a biopsy, because here we suggest a colonoscopy of the terminal ileum, the terminal part of the small intestine, where you are more likely to find the pathology of Crohn's disease. So you might not need to do a rectal colonoscopy, because if you're suspecting Crohn's disease and if your fecal calprotectin is positive and there is high suspicion of Crohn's disease, so upper colonoscopy would be much better to visualize the stomach and the small intestines. Again, if a small bowel disease like Crohn's disease is suspected, you can do a magnetic resonance enterography, MR enterography, or CT scan enterography. The second possibility is ulcerative colitis, but as I've just said, ulcerative colitis is very unlikely in the absence of blood in the stools. Here you can see a picture taken by through the colonoscope, and you can see ulcers in the mucosa of the large intestine. Ulcerative colitis is, we are explaining it here because it's also a chronic inflammatory bowel disease that also has an immune element. And just like any chronic disease, it will cause a long-lasting inflammation. But in addition to the ordinary inflammation that is found in case of immune reactions, or autoimmune cases of long-standing diarrhea, there are ulcers. And the ulcers this time are not in the ileum, in the terminal part of the small intestine, but they are present in the large intestine. Like the colon and the rectum. But it also causes pain, abdominal cramps, bloody diarrhea. But the pain and the abdominal cramps are rather in the central and lowermost part of the abdomen, not epigastric, as in the condition of our studied patient. There is no effective cure for ulcerative colitis, nor for Crohn's disease, but what we try to do is to try to minimize the amount of inflammation in order to like bring on longer periods of improvement, longer periods of remission. And by remission, we mean periods when the symptoms are minimized as much as we can so that the patient can feel some relief. When you prolong the periods of remissions, then you are minimizing the periods of exacerbation or flaring up or augmentation of the worsening of the symptoms. The exact cause of ulcerative colitis is unknown, but it is considered and classified as under autoimmune diseases. But so we know the mechanism, but we don't know the exact cause that triggers that autoimmune reaction. Just like any autoimmune reaction, your immune system gets confused and your tissues are mistaken for being foreign and are attacked by your immune system. So your immune system is attacking your own intestinal mucosa. Of course, there are underlying factors that favor the occurrence of ulcerative colitis and of autoimmune diseases in general. So there are genetic factors. Of course, if you are genetically predisposed, you are more likely to get it. But if the environmental conditions help this, because as we always repeat, that it's not only enough to have the gene, but it's also important to have the environmental conditions that help expression of that gene or that help turning on of that gene. So if you have a first-degree relative who has inflammatory bowel disease, then you are significantly at risk. The second factor is the immune system itself. The immune system is abnormally reactive to environmental factors or to bacteria that are present in the gut. So sometimes the trigger is a bacterium, which is an endogenous factor, but sometimes the trigger, like in celiac disease, is gluten, which is an external factor that you ingested from your environment. Age, of course, and ethnicity are important because ulcerative colitis is usually diagnosed under the age of 30, in younger age groups, and therefore it doesn't match perfectly with our clinical case. And it's most common in white individuals. Our patient is a white individual, and those of Ashkenazi Jewish descent. The symptoms, of course, just like in any other autoimmune disease, there are fluctuant between periods of remissions when the symptoms are diminished and periods of flaring up or exacerbation when when the symptoms are exaggerated. And there are even periods when there might be no symptoms at all if the condition is not very severe. But usually the diarrhea is bloody. So we have a diarrhea, frequent loose stools, bloody diarrhea, almost always associated with mucus and pus. Mucus is due to over stimulation of the mucus secreting cells or the goblet cells in a trial to protect the small intestine against these ulcerative procedures that are or processes that are ongoing because of the autoimmune. And pus is due to death of the white blood cells that came to rescue your body, or because of inflammation, secondary inflammation, or even because of death of the white blood cells after they achieve their task in their immune response. Of course, because of the ulcers and the inflammation, we will have abdominal pain, we will have cramping, and maybe also rectal pain, because ulcerative colitis affects not only the descending colon and the transverse colon, but it also affects the rectum. And because of this, the patient might suffer of periods of urgent, sudden need for bowel movement. This is very similar to the dysentery in case of amoeba and amoeba histolytica. Patients suffer from this urgent desire to micturate, and this is very characteristic of amoebal dysentery, and that's a differential diagnosis. We also have, of course, weight loss because there is, of course, malabsorption because of the diarrhea. There isn't enough time for absorption. Fatigue and fever are rather due to the autoimmune process. This immune overreaction is associated with the release of pyrogens, which are chemicals which circulate in the blood and reset your temperature regulating center in the hypothalamus at a higher temperature. But interesting to know is that the elevation of temperature in autoimmune diseases is moderate, meaning that the temperature never increases more than from 37.5 to 37.8, not high fever. Of course, we need an endoscopy, a colonoscope, and maybe also a biopsy. And we need a blood test. Several blood tests can be done here. What blood tests? For example, again, ESR, erythrocyte sedimentation rate, CRP, serum C-reactive protein for the chronic inflammation, maybe also certain antibodies to assess to do an immune profile, because maybe the condition is associated with other underlying or accompanying autoimmune diseases. You can also do a CBC, of course, a complete blood picture, to see if the patient is anemic because of the continuous loss of blood. Stool samples, of course, will reveal the presence of blood. The treatment of ulcerative colitis, as we said, doesn't aim at curing ulcerative colitis, but at increasing the periods of remissions and diminishing the periods of flaring up or exacerbations. And we usually start by, in all autoimmune diseases, we usually start by an induction where you give relatively higher doses, whether of corticosteroids or immunosuppressants, and then you gradually taper those doses for maintenance. So the aim of the induction therapy is to stop the flares, the flaring up of the disease and of the symptoms. And the aim of the maintenance is to keep the symptoms at bay. Usually we start by, of course, anti-inflammatory drugs, but also cortisone or corticosteroids. They are one of the most potent immunosuppressives and anti-inflammatory drugs. So the corticosteroids inhibit the immune response, and therefore they are immunosuppressants, and at the same time, they prevent the inflammation that accompanies the immune response. So they are also considered anti-inflammatory drugs. But in severe cases, if the corticosteroids are not enough, or if you need a very large dose of corticosteroids that might lead to peptic ulceration or hypertension or hyperglycemia, which are all common side effects of steroids, then we refer to immunosuppressants or even to biological therapy. Biological therapy is very interesting because it's very expensive, but very interesting. What is biologic therapy? You use very specific proteins that are genetically engineered and that are derived from living cells. By genetically engineered, maybe we mean cloned, or genetically the genes were cloned, or maybe we mean that they were slightly modified. Their genes that produced them were slightly modified. And what's interesting about them is that they do not have serious side effects on the body. Why? Because biologic therapy usually targets certain specific areas of the body. So what's interesting about them is that they are very specific, and for example, they do not cause suppression of the bone marrow or any other side effect as those that are found in case of the ordinary immunosuppressives. Of course, if all this fails, then we refer to surgery and we remove the part of the colon that is diseased, and usually it's a huge part of the colon, most of the colon, so we call this colectomy. Can we live with ulcerative colitis? Yes, we can live with ulcerative colitis by modifying the diet and avoiding stress. Although they are not the cause of the autoimmune disease, but they cause flaring up. So you will learn that gradually you will learn that there are certain specific types of food, like spices, for example, which make you feel very uncomfortable after ingesting them, and also stress. So they do not cause the disease. They are not the underlying cause, but they trigger the flare-ups, or they trigger the periods of exacerbations. Of course, if you have ulcerative colitis, unfortunately, you will be treated for life. So it's an ongoing medical management, and there should be follow-up because it might end up by a serious condition, which is cancer colon. And now we refer to, or we begin the third possible autoimmune cause, which is celiac disease. We have discussed it briefly in the first video, and now we're going to discuss it in more details. Why are we focusing once again on celiac disease in this second video? Because it fits more with our condition, with this 63-year-old 63-year-old lady who was suffering from chronic diarrhea. First of all, because celiac disease, as we said, it's due to gluten hypersensitivity, and it can first present in an older adult or in older age groups. And the presence of the autoimmune disease in our patient, which is already a mixed connective tissue disease raises the suspicion or increases the risk that this patient might also have autoimmune diarrhea. And the symptoms match perfectly. Celiac disease results in chronic diarrhea if you're chronically ingesting gluten, together with bloating and, of course, fatigue because of malabsorption. When you do not digest food well and your mucosa is inflamed, then there will be malabsorption or impaired absorption of food, impaired absorption of iron, and therefore you might suffer from iron deficiency, anemia, and fatigue, and also weight loss for the same reason. What are the features that fit our case and what are the features that are less typical? The features that fit our case are the marked bloating, the loose stools, the fatigue and lethargy, and the history of a mixed connective tissue disease, which we call the autoimmune background. The features that do not fit perfectly are the site of the pain and that the pain is relieved by defecation. The site of the pain is atypical, of course, because in our condition, in our patient's condition, it was epigastric pain, while in ulcerative colitis, it is lower abdominal pain that's not relieved by defecation because the ulcers are there and the pain is continuous. And although we describe it as being chronic because it has lasted for a month, yet the onset was sudden. Over one day, she suffered from these symptoms, and usually in autoimmune diseases, the onset is gradual. In such a case, as we said before, there is a very interesting test that we do. It's a blood test called immunoglobulin A, tissue transglutaminase. And this is elevated because of, you know, that immunoglobulin A is a surface immunoglobulin. And in case of gluten hypersensitivity, immunoglobulin A is high in the rectal mucosa and in the intestinal mucosa, and this will be reflected on the blood. But as we explained in the previous video, and you can refer to it to understand more, we have to do the total immunoglobulin A level, because in some people, the total immunoglobulin A level is low, and therefore you might have a falsely negative or low immunoglobulin A tissue transglutaminase, not because the patient is not suffering from celiac disease, but because their total immunoglobulin A is low. And another precaution other than leveling total immunoglobulin A is avoiding starting a gluten-free diet before the test. We want you to continuously eat gluten for a week, for example, before doing the test, because if you stop eating gluten, the reaction, the autoimmune reaction, the immune reaction will stop actually, and we might give you a falsely negative test. We want to see the reaction of your body while you are ingesting, still ingesting gluten. And then after having known all this, we have to recapitulate the condition and to brainstorm on the condition. So the age was 63, as I said, taking cataflam, Nexium as a proton pump inhibitor, steroids, a long history of autoimmune disease. We haven't written here the corticosteroids, although they are very important, not responding to any medication. And according to what we have said in the previous video and in this one, we would place these conditions higher on the list. Number one, microscopic colitis. Number two, non-steroidal anti-inflammatory drug-induced enteropathy. Number three, small intestinal bacterial overgrowth and associated with gastrointestinal dysmotility, of course, celiac disease, Crohn's disease and ulcerative colitis. We haven't written ulcerative colitis. We can do further brainstorming in the next video. I hope you liked this video and found it useful. And if so, then please click on like. Give us your feedback in the comments. Subscribe if you haven't already. Subscribe if you haven't already, and share the video with your colleagues, your classmates, in order to expand the benefit from this video. Thank you, and see you on another video.